A very good evening to everyone. Now the topic we'll be discussing is migraines. So what is migraine? So migraine is by definition, it is an episodic headache, which is primary headache, disorder, which lasts for 4 to 72 hours. So what is primary headache? When there is no structural abnormality present, we call it as a primary headache. So it is an episodic primary headache disorder lasting for the typical episode lasting from 4 hours to 72 hours. And usually the patient would always say that the headache is very severe in nature. The patient will complain of a headache which is unilateral in nature. It is throbbing and it worsens with exertion. So it worsens with exertion, and it is usually associated with nausea. There is photosensitivity. That is, the patient will tell you that the headache which is there, it gets relieved when the patient enters a dark room. So photosensitivity is there. Phonophobia is there. The patient is typically scared of sounds. Sound will cause increased headache in that patient. And there is sensitivity to odors. So as we know, a typical smell, patient will say a typical smell, maybe the smell of petrol will increase the headache or it will cause the headache. Now, headache, migraine, we know, will be seen with aura and without aura. So aura is a typical set of sensory or motor symptoms, which we will be discussing later on. It can be positive symptoms, set of positive symptoms, and also a set of negative symptoms. So aura is seen in cases of 15 to 30% of the patients. What we usually see is migraines begin at puberty or young adulthood. And which is the good news is the patient's migraine symptoms will decrease with age, and it usually vanishes after 50 years of age. Now, pathophysiology of migraine. So there are a lot of mechanisms that has been postulated for the pathophysiology of migraine. So the number one pathophysiology is, which we usually follow, is vasodilation of the intracranial vasculatures. So there are some neurochemicals like serotonin and calcitonin gene-related polypeptide, CGRP, which causes vasodilation. And there is a throbbing kind of pain that the patient complains of. Second postulated mechanism is neuronal dysfunction, which leads to the stimulation of trigeminal ganglia, which again leads to some vasoactive neuropeptides release, like substance P, which causes pain, CGRP, neurokinin. So all these chemicals will cause pain. This will cause pain how? It will cause inflammation of the intracranial vessels and the dura mater, and that will again lead to the symptoms of migraine. And we have seen that there is genetic susceptibility. That means that migraines runs in families. So the first degree relatives or the second degree relatives of the patient will usually give the history of migraine. What are the clinical manifestations of migraine? We have seen that migraine is a disorder of recurrent attacks, and these attacks usually last from hours to days. And a typical migraine attack usually goes through the following stages, like prodrome stage. There is a stage of aura, there is headache, and there is postdrome. Now we will be going and discussing through all the stages. First is prodrome. So as the name suggests, before the episode of headache comes in, the patient will go through this stage. It is seen in mostly like up to 60% of the patients, and it appears from 24 to 48 hours prior to the onset of the symptom of headache. And what are the symptoms that are seen in during the prodrome phase is patient may have euphoria also, patient may have the depression, there is irritability, food cravings, constipations, neck stiffness, and increased yawning. Second stage is the aura stage that we always hear of. So what is aura? Aura is a set of sensory symptoms or a set of symptoms which can be positive or negative in nature. And usually these symptoms, these sensory symptoms are seen like less than an hour just before the headache starts. So the aura is seen in 25% of the patients. So what are these positive and negative symptoms? So how I remember is positive symptoms is something that is getting added to the symptom list. So it can be visual symptoms, like the patient will be seeing some bright lines, shapes, objects in front of the eyes. It can be auditory symptoms like tinnitus or noises that the patient can hear. Second, we see there is somatosensory symptoms like burning, pain, or paresthesia. And motor symptoms may also be seen like jerking or repetitive rhythmic movements. Now, negative symptoms. So negative symptoms means something that is, there's a loss. So loss of vision, there can be loss of hearing, loss of feeling, or there is a loss of ability to move a part of the body. Now, there are few types of aura that we usually see in patients of migraine, out of which visual aura is something that is mostly seen in most of the patients. There are some others also. So what is visual aura? So visual aura classically begins as a small area of scotoma or visual loss, or a small area of blind spot, which is usually seen lateral to the point of visual fixation. And it might appear as a bright spot or an area, like I said, it can present as an area of scotoma or visual loss. And what we see is over the 5 minutes to 1 hour, the visual disturbance expands and the shape changes. So when the whole thing resolves, vision usually returns first to the areas of the central vision, which was affected first, and then subsequently it comes back. The other types that I was talking about was sensory aura, which is typically seen to be following the visual aura within few minutes. And although it may also occur along with the visual aura or without the visual aura. And what we see is there is a tingling sensation in one particular limb or on one side of the face, which then migrates to the other side of the face and down the limb. Like we all know that in case of migraine, it starts from one side of the body, unilateral, and it can spread to the other side also. And there is a slow spread of positive symptoms, that is scintillations. So what is scintillations? These are flash of lights that can be seen in the visual field, or there can be tingling sensations, which is followed by some negative symptoms like what? Like scotoma, which is a blind spot, or there can be areas of numbness that can be seen or felt by the patient, and is quite characteristic of migraine with aura. The third type of aura that is seen is language or dysphasic aura, which is less common, and it is transient, mild. There is wording difficulties or dysphasia by the patient. Motor aura is quite rare. It can be seen in the limbs or possibly over the face on that particular side of the body. Now, the aura symptoms may occur, either it can occur singly or it can occur in sequence or in a group, okay? And it develops gradually over 5 minutes. It can be differentiated from transient ischemic attack or stroke. And migraine aura without headache also may occur in patients. Again, we have to differentiate it from the transient ischemic attacks, especially when the patient presenting to you is an elderly patient. Now the second phase, that is the headache. There's a the spelling error here. So the headache is usually unilateral in nature, but it is not always unilateral. It can present on the other side of the head also. It is pulsatile or throbbing in nature. So this is a typical character of migraine, which is it is a throbbing headache that the patient complains of, and it is severe in nature and it gradually increases. Patient also complains of feeling of nausea and vomiting. There is photophobia or phonophobia along the attacks. During the attacks, the patient feels these things. And like I was saying, the patient will say that I feel relief only when I lie down in a room which is dark and which is without any sounds. And any untreated headache can last from few hours to even few days if it is not treated or any abortive management is not started. Then postdrome. So after the headache comes the postdrome phase. Then the spontaneous throbbing of the headache resolves. The patient feels postdrome. And this postdrome is typically seen with sudden head movement causing the pain in the location of the antecedent headache. And during the postdrome, the patient can feel drained or exhausted, or even atypically, the patient might say that he feels a mild elation after the headache gets over. As we know from our experience that the migraine patient will say that there are some typical triggering factors which causes the headache or precipitates the headaches. So it can be emotional stress, it could be any hormonal therapy, it could be due to starvation, prolonged. If the patient doesn't eat food for a long time, there might be headache. Weather changes, sleep disturbances, lack of sleep, any strong smell, any neck pain can lead to migraine attack. There can be flashing lights which causes the migraine attack, smoking, alcohol, food like cheese, chocolate, exercise, sexual activity, and physical exertion. Now, coming to the diagnosis, like we said before, the diagnosis of migraine is mainly clinical diagnosis. So we have to take a proper history, and based on the history, we'll be making the diagnosis. So there is common migraine, which is without the aura and with the aura, and there is classical migraine, which is without classical migraine with the aura, and there is common migraine without the aura. So migraine without the aura is there are 5 attacks, that is at least 5 attacks will be seen, and the headache with attacks will be lasting from 4 hours to 72 hours. And the headache will have at least 2 of the following 4 features. What are the following 4 features? First is it will be unilateral in nature. It will be pulsatile in quality. There will be moderate or severe pain. There will be aggravation or aggravation by or causing avoidance of routine physical activity. There, during the headache, at least one of the following features will be there. That is nausea, vomiting, photophobia, or phonophobia. And if the headache is not better accounted by any other ICHD classification, that also we have to check. Then classic migraine, which is with the aura. So what we see here is at least 2 attacks fulfilling the criteria B and C. So what are criteria B and C? There is usually 1 or equal to 1 or more than 1 aura symptoms like visual aura, sensory aura, speech or language aura. There is motor symptoms, there is brainstem symptoms, and retinal symptoms. Then at least 3 of the following 6 characters will be seen. One is the aura symptom, usually which is lasting over 5 minutes. There is 2 or more aura symptoms occurring one after the other in succession. Then there is each individual aura symptom, which is lasting from 5 to 60 minutes, that is 1 hour. And then at least 1 aura symptom, which is unilateral, and at least 1 aura symptom, which is positive in nature, positive aura symptom will be there. Or the aura is accompanied or followed by within 60 minutes by a headache. And again, like the other one, if it is not better accounted by any other ICHD diagnosis, we will be classifying this classic migraine with aura. Now, the diagnosis is mainly clinical, but there are some variants of migraine which we should keep in mind while we are seeing a patient of migraine. So there can be hemiplegic migraine, where there is motor weakness seen in the patient, which is typically motor weakness is typically unilateral with or without the sensory and visual symptoms. It can be sporadic or there is a family history present. Second type is retinal or ocular migraine, which is kind of rare and characterized by repeated attacks of monocular blindness, one eye, like patient won't be able to see in one eye, or there can be blind spots which is seen, which is lasting for less than an hour, and it is associated with or followed by headache. Third type is migraine with brainstem aura or basilar migraine, which is again an uncommon type. And this type is usually because of the symptoms that is occurring or originating from the brainstem. So what we will see in this patients, there is combination of vertigo, dysarthria, tinnitus, diplopia, ataxia, and decreased level of consciousness without associated motor weakness. Other types are vestibular migraine or migrainous vertigo, which is characterized by episodic vertigo along with headache and other clinical features of migraine. There can be a rare type, which is menstrual migraine or catamenial migraine, which is headache occurring with the onset of menstruation. But it's not like that the women with menstrual migraine may also have migraine at other times of the month when the patient is not bleeding. Now, what are the indications for doing and neuroimaging, or when will you order for neuroimaging in a case of a migraine patient? So typically when the patient says, I've had the worst kind of headache in my life, this was the worst kind, and this is the first time I'm having such a bad episode of headache, you will ask for neuroimaging. And say, suppose if the pattern, the frequency, or the severity of the headache keeps changing and there is a significant change, you will ask for a neuroimaging. If new or unexplained neurological symptoms gets added, if the headache is always on the same side, even though on the definition of migraine, we were saying it is a unilateral type, but it might be that the migraine symptoms, it starts from one side unilaterally and it spreads onto the other side. So if the patient gives the history of headache, which is universally like on the same side, then you will ask for a neuroimaging. Headache which is not responding to any other management. And headache, like I said, migraine usually resolves after the age of 50. So any new onset headache which is starting after age of 50, you will ask for neuroimaging. If the patient has a new onset headache and the patient has known cancer or any HIV infection, or when there is associated symptoms and signs like fever, then neck stiffness, papilledema, cognitive impairment, and personality changes, then we will ask for a neuroimaging. Now, differential diagnosis. So there are several, in the evaluation of headache, we have learned that there are several other kinds of headache. The most confusing ones, which might be confused with migraine, is tension type headache and cluster headache. And these are also the ones which comes to our OPD. So tension type headache, like from the feature, we know that it is there present as a band. It's like a pressure band over the head. Cluster headache is usually like a boring kind of a patient complains of a boring kind of pain in the eye, and there will be autonomic symptoms which are seen along with the headache. So a cluster headache, and also the symptoms will occur in clusters, like there will be symptom-free period in between the episodes of headache. So these are the ones, and we should know how to differentiate from the clinical features of each type of headache, that it is different from the migraine. Now, there are some conditions which can be CNS conditions, which can be confused with these kinds of headaches. So hemiplegic migraine, migraine with brainstem aura, then vestibular migraine and retinal migraine can be confused with some CNS conditions like what? Like stroke, transient ischemic attacks, some CNS infection, and intracranial space occupying lesion. So management of migraine. So management of migraine is mainly abortive management and preventive management. So preventive management is a precautions or some prophylactic medicines that you keep giving to the patient. And then there are, when these medical management fails, we have some non-pharmacological interventions also. So we'll be discussing one by one. Now, general management when a patient comes with migraine. So we have to teach the patient. Like any other pain condition, we should properly sit with the patient and educate the patient, make the patient understand about what is going wrong with the patient's body. So, so educate the patient about the disease, and like also you should educate the patient about the use and the abuse, overuse of the medicines that are available for the treatment. We should typically tell the patient to maintain a headache diary and to eliminate the triggers, which if the patient is able to find out a pattern which is causing or triggering the headache, then the patient should be careful not to go cause the triggers to themselves. Then adequately strong agents for severe headache, responding to NSAIDs or a combination of analgesics. So a typical set of abortive medicines will be there that the patient should be aware of, and careful choice of drugs should be known to us. And so in case of pregnant patients, we usually go for, if the patient is suffering from headache, we'll only go for paracetamol, which is supposed to be the safest of all pain medicines. Now coming to abortive drugs. So paracetamol is number one. Second, we will go for ergot alkaloids. So ergotamine and dihydroergotamine plus or minus caffeine is used. The tablet is known as Migraine, which we use. So 1 milligram of ergotamine with 100 milligram of caffeine tablets combination is found. So what does dihydroergotamine cause? It is an alpha blocker and is a weak arterial vasoconstrictor and potent venoconstrictor. So initially in the pathophysiology, we had known that it is a throbbing kind of headache. Usually one theory was saying that it is due to the vasodilation of the intracranial vessels. So this dihydroergotamine acts through venoconstriction and vasoconstriction and causes the relief of headache. And then it has dihydroergotamine is seen to have fewer side effects than ergotamine, and there is no physical dependence or rebound headaches, which is an important thing. But we should be careful that it cannot be used in cases of hypertension or the patient with an ischemic heart disease or in an elderly patient. Next is NSAIDs. All NSAIDs are seen to be beneficial for a patient of migraine, whether it is with aura or without aura, NSAIDs can be given. Then serotonin 1B and 1D agonist like triptans. So sumatriptans, which is available in 50 mg or 100 mg of zolmitriptan, can be used as an abortive medicine. So how it acts? It inhibits the release of vasoactive peptides, and it ultimately causes the inhibition, inhibits the inflammation and promotes vasoconstriction. It is the agent of choice, but it should be individualized from patient to patient. Patients who do not respond to one triptan can be like switched on to some other also. And we should keep in mind that these triptans should be avoided in patients with hemiplegic migraine or basilar migraine. It is absolutely contraindicated in case of uncontrolled hypertension, ischemic stroke, ischemic heart disease, patients of angina, and also obviously in pregnancy. Some other options that we have is parenteral dexamethasone, which can be added to the abortive therapy, and it reduces the rate of early headache recurrence. But long-term glucocorticoid therapy has potential risks and should be avoided. Opioids and barbiturates like and also fentanyl can be used, but are not associated with any higher like relief. But we can use this opioids and barbiturates to give relief to a patient who is not responding to the above mentioned drugs. So general guidelines, like initially when I said that a patient of migraine will have vomiting. So with vomiting and without vomiting. So patients who have mild to moderate migraine attacks and which is not associated with vomiting, we will go for simple and analgesics like acetaminophen, or we can go for a combination of analgesics as the first treatment choice. Then mild to moderate attacks, which is associated with severe nausea and vomiting, we can go for an antiemetic drug, which can be added along with the combination of analgesics that we are providing. Then moderate to severe migraine attacks, which is not associated with vomiting or severe nausea, we can go for triptans and ergot alkaloids. And for variable severity migraine attacks associated with vomiting and nausea, we can go for subcutaneous or nasal triptans. Now, what are the preventive management? The preventive management I've already discussed before. So preventive management aims to reduce the frequency, the severity of, and the duration of the headache. And it will also, if the patient is careful enough, it can help to improve the responsiveness to the medical management. So patient preventive management is to prevent the progression or transformation of episodic migraine to chronic migraine. So if the migraine attacks are continuing, it can transform into a chronic daily headache. So the preventive management will prevent that being happening. And when the migraine attacks causes significant disability, despite any appropriate acute management, will go for a preventive management. So there are a set of drugs which will be there for preventive management. Therapeutic lifestyles like good sleep hygiene, avoiding triggers, and like any other pain patient, like regular exercise, taking care of themselves, like regular meals, because starvation is known cause to trigger migraine. Headache diary that I was mentioning. Now, drugs which are used for preventive management. So basically beta blockers, the metoprolol, timolol has also been mentioned. The most common ones that we use is propranolol, 40 to 120 mg given to the patient. Anticonvulsants like Valproex, 250 milligram to 1000 milligram can be given. Topiramate from 50 milligram to 200 milligram can be given, and it is as effective as propranolol. And flunarizine, 5 mg, 5 milligram to 10 milligram is given. It is, and also calcium channel blockers can be given. Now, some other preventive drugs which is given for the treatment of migraine are angiotensin converting enzyme inhibitors, ACE inhibitors, ARBs, angiotensin 2 receptor blockers has been proved to be useful. SNRIs, the ones like duloxetine, which we commonly used in a pain OPD, can also be seen to give good results in case of chronic migraine not responding to any other treatment. Tricyclic antidepressants like amitriptyline, nortriptyline can be given, and can be given for a migraine prevention. And it has also been seen that gabapentin can be used. Now, there are some upcoming treatment which is not very frequently used, but we should know about, is the monoclonal antibodies like CGRP, monoclonal antibodies which is acting against CGRP, calcitonin gene-related polypeptide. So the eptinezumab, erenumab, these are the drugs that can be used. Now, other suggested treatments are acupuncture can be tried. Then transcutaneous electrical nerve stimulation, which acts by gate control theory, can be used for patients of chronic migraine. Botox injection has been used to be botulinum toxin type A can be used for the relief of chronic daily headache and preventing daily migraine to transform into chronic daily headache. We can use this. So usually 4 to 6 units per site injection has been done, and it is seen to be given at the site in the area of Bindi, so procerus muscle, then corrugator muscles, and frontalis muscle, then temporalis area, and occipitalis and trapezius side, and cervical paraspinal muscles. These are the sites where Botox injection is used, and it is a new upcoming treatment that can be used for chronic daily headache. So coming to the conclusion for migraine, we should know that it is kind of one of the most common type of headache that presents to us. We should be able to differentiate it from the other kinds of migraine. From cluster headache or tension type headache, patient, it can be confused with occipital neuralgia, which is usually with the history, we will know that in the area of C2, C3 nerve roots, the patient will have the headache. So we'll be easily able to differentiate it from there. Tension type headache will be like a chronic tension band present. Cervicogenic headache, just the class before this, we know that with neck movements, the patient will have pain, and cervical facet is seen to be tender in these patients. So it is very important to take a proper history and then a proper clinical examination, and that's how we can come to a diagnosis of headache. Thank you.